Great. Good evening. How are you guys? Good. Very good. Okay, so I'm recovering and I thought I'll take the class. I'll start taking the classes because otherwise we'll be delayed, right? So where we were in the last class, guys, can someone recall? Can someone tell me? Oh, you don't remember? HTN pathology. Okay. HTN pathology completed. Okay, so we'll go to the drugs. Cool. Let me share the screen, guys. Yeah, so HD pathology, HTN pathology, everything is covered. Now we'll go to the HTN therapy. Okay, great guys. So let's start. Good evening. Today we'll be talking about the therapy of hypertension, the treatment of hypertension. So I think the goals of therapy we have already studied in the earlier class when we were talking, about the different blood pressure measurements and different, blood pressure goals in different patients, like, the kidney patients or renal insufficiency patients or in the diabetic patients. So, and in the cardiovascular patients, stroke patients. So those things we have studied in the earlier class, right? So, but still, what we should focus, our minimum target of the hypertension or the blood pressure, it should be, lesser than 130 by 80 in the patients with chronic kidney disease and diabetes. And normally, we should keep our blood pressure. Normally, we should keep our blood pressure in severe hypertension patients in the emergencies and all. We should take it down up to 130 by 80. Okay, so let me mute everyone. Great, no problem. It's fine. Okay, so we should take it the target of 130 by 80 mmHg, right? And it should, always be focused that, in the hypertension patients, or the patients who have hypertension, they are at the higher risk of cardiovascular problems. They are at the higher risk of cardiovascular diseases, right? So we should keep always in our mind that we have to treat hypertension in such patients who are on the higher target or who have the higher score or higher probability of getting CVT. Okay, and we should be always, careful about the renoprotective drugs, and in the BP control, we should always, think of that, whatever we are giving or whatever we blood pressure we are maintaining, it should be renoprotected. It should protect the kidney, right? And we should always, also think of like reducing the risk of stroke and achieving the SBP goals, especially in the persons of more than 50 years of the age. So in elderly, it is very important to maintain the blood pressure, right? Now look at the evidences why we should, keep that. Because see, here you can see blood pressure reduction of 2 mmHg decreases the cardiovascular risk of cardiovascular event by 7 to 10%. Understand, only 2 mmHg blood pressure can decrease the risk of cardiovascular events by 7 to 10%. So if we are reducing the blood pressure by 2 mmHg, the reduction in ischemic heart disease will go up to 7% down, and risk of stroke will go up to 10% down. So it is very important. So if you are controlling by 20%, 20 mmHg of blood pressure, your risk of cardiovascular diseases or stroke will come down to, around 70%. 70%. If you are reducing this much blood pressure, or if you are keeping the blood pressure in control, you can reduce the risk of stroke and high, cardiovascular disease by 100% even. Okay, so it is not that I am saying that there was one study meta-analysis done with the, using the 61 61 studies was taken in this meta-analysis, and they have observed around more than 1 million adults, and that meta-analysis says that reducing the blood pressure by 2 mmHg decreases your cardiovascular event risk or stroke risk by 7 to 10%. Okay, so that's why it is very important to keep our hypertension in control. So what are the things about lifestyle? Weight reductions. If we are reducing the weight, see, look at this. If we are reducing our weight by 3.8 kg in 18 months, look at this. If we are reducing in the patients of hypertension, if we are reducing the weight by 3.8 kg, we are reducing the blood pressure by 2.9 to 2.3 mmHg, means 2.5 or 3 mmHg blood pressure we are reducing. So 3 mmHg means how much? Around 15%, around 10 to 15% of the risk of cardiovascular problems we are reducing. Okay, we are reducing the risk of cardiovascular problems by 10 to 15% just by reducing our weight of 3.8 kg. That's why weight reduction is very important in hypertensive patients, because it directly leads to the blood pressure control, and the blood pressure control directly leads to the CVD risk control. Okay, then exercises. Look at the exercises. Following increased physical activity, BP falls up to 6 to 7 mmHg in 3 months. Okay, BP falls up to 6 to 7 mmHg if you are just going for brisk walk and cardio exercises. Normal cardio exercises, whatever are suggested by the physio or whatever are suggested by the physician. If you are doing that, your blood pressure will come down by 6 to 7 mmHg. That means you can reduce the cardiovascular risk by 20%, at least 20%. So everything is related to your healthy life, because ultimately you are suffering with cardiovascular problems if your blood pressure is high. So you can control the blood pressure by different means: by lifestyle modifications, by weight control, by weight reduction, by exercises, by food, right? So this is the major algorithm to treat the hypertension. This is the major algorithm to treat the hypertension. So see, look at this, look at this. If the initial BP is around 140 to 190, if the initial BP is around 140 to 190, or it is between 160 by 100, 140 to 160 by 90 to 100, if your initial BP, then you can immediately start the patient on one agent and lifestyle management. One agent plus, we can say, exercise and weight reduction and food habits changing. Okay, lifestyle modifications. So one agent means any based on the albuminuria. If you have albumin in your urine, based on that, if you have albuminuria, then you can start the patients on ACE inhibitors or ARB and ACE are the first choice of the drugs in hypertension anyways, whether the patient is having the albuminuria or not. But in the patients who are having the blood pressure from 140 to 160 SBP and 90 to 100 DBP, then you can start with ACE inhibitors or ARBs. Okay, whether they have albuminuria or not, the low dose ACE inhibitors are recommended. Low dose means, like, if we are giving ACE inhibitors, if we are giving ramipril, then we can start with 2.5. Okay, if we are giving enalapril, we can start with 2.5. So there are different doses that I'll come to in the later slides. So we should start with first choice of the drug, that is ACE inhibitors or ARB. If the BP is more than 160 by 100, okay, not by 140/90 or not between 140 to 160, but if it is more than 160 by 100, then definitely lifestyle management along with two agents. Okay, along with two agents like maybe ACE inhibitors or ARB. Along with that, you can consider if there is albuminuria, you can consider CCBs or diuretics, or if there is no albuminuria also, you can consider CCB or diuretics. So first choice of the drug is ACE inhibitors and ARB. But Indian settings, still in the Indian settings, we start with CCBs. You must have seen that they give amlodipine, right? They give amlodipine first. If you are going to the doctor, they'll give you AMLO 5, AMLO 2.5. This is the Indian practice scenario. Okay, this is the Indian practice scenario. But usually nowadays we are changing. In our hospital, we don't give amlodipine at all initially. We start with either ACE inhibitors or ARBs, maybe telmisartan, olmesartan, or anything. But we start with ACE inhibitors or ARB, not with the amlodipine, because amlodipine has certain drawbacks, certain side effects, pedal edema, or there are multiple other side effects, angioedema and all. So those side effects are also there. Okay, so we should start, if the blood pressure is 140 to 160, then we should start with single agent, that is ARB or ACE anything. And if you have more than 160, then we should start with two agents, that could be ARBs plus CCB, or ARBs or ACE inhibitors, or ARB plus CCB or diuretics. Okay, that can be done easily in the patients. Now, if the blood pressure is not controlled right now, if the blood pressure is like, after some time we will assess the BP again, and we'll check for the adverse event. So if the treatment is well tolerated and target is achieved, target means 130 by 90, if we are achieving the target, then we can continue the same therapy. Okay, we can continue with the same therapy. If we are not meeting the targets, if we are not meeting the targets, then we can add one more agent. Okay, we can add one more agent. That agent could be either along with ACE inhibitors and ARB, we can add CCB. If it is monotherapy, we can add CCB or diuretics. If it is dual therapy already, like ACE inhibitors or ARB and CCB, then we can add diuretics. Okay, in diuretics we usually go for spironolactone. Then otherwise we go for thiazide diuretics as well. That I'll tell you. There are multiple other diuretics, so we can add the triple therapy. Okay, and then after some time again we will assess the patients. So when we are assessing the patients, if the treatment is well tolerated, then continue the therapy. If the patient is not tolerating the therapy and showing some kind of side effects, then in that case what to do? In that case we are going for mineralocorticoid receptors for sure, that is spironolactone. Okay, that is spironolactone. So add spironolactone for sure. Okay, spironolactone is very important to add that time, right? So this is the major algorithm to treat hypertension. Okay, that's how we treat the hypertension. So just summary wise, if the blood pressure is 140 to 160 mmHg, we will start with one agent. If the blood pressure, I mean, definitely lifestyle modifications will be there along with the single agent. If there is blood pressure more than 160, then dual agent, dual therapy along with the lifestyle modifications. Okay, then check after some time. After some time, if we are checking again, if it's not controlling, then we can add the third agent, any kind of third agent, which will be either CCBs or diuretics, or maybe sometimes beta blockers also. But beta blockers are least used nowadays. Okay, beta blockers are used in the cardiovascular problems along with hypertension, heart failure with hypertension, or maybe sometimes in diabetes with hypertension. But beta blockers are not the first choice or the second choice in treating the hypertension anywhere. Okay, according to the new ACC or AHA guidelines, or new what we say JNC guidelines, or according to new SC guidelines, these are the these are like beta blockers are not the first or second considerations, right? Now, what are the lifestyle modifications we can check for? First, definitely the salt reduction. I'm so sorry. First is salt reduction. So there is a strong evidence for a relationship between high salt intake and increased blood pressure. Definitely, that we all know. That is, the science says. So we can just reduce the salt. Okay, we can reduce the salt first by 50%. There is the tapering reduction in the salt also. So for the first week, we can reduce by 50%, and then we can check out if the person is very well maintaining the blood pressure. Then we can go ahead with the 50% reduction. If the person is not even maintaining, then after some time, whenever the doctor suggested, or whenever you feel like the patient is going to triple therapy or double therapy, we can again reduce the diet salt by 50%. So but by 25%, when we reach to the 25%, we should not go less than 25% salt intake anytime in your lifetime. Okay, then healthy diet, definitely healthy diet is very important. We call it DASH diet, DASH diet. So you guys, I must say you go to the dash4health.com. This is the website where you will get about the DASH diet. So can someone tell me what is the DASH diet exactly? Guys, please tell me what is the DASH diet. I'm waiting for you. What is DASH diet? DASH. What is dash diet? Can someone explain dash diet to me? Yes, right. Oh, you want to speak? I'll just wait. Okay, you can speak now. You can speak also. What is dash diet, guys? No, that is that I know. Dietary approaches to control the hypertension. What exactly DASH stands for? Tell me. You can tell me the content also because it's written here. Eating a diet that is rich in whole grains, fruits, vegetables, polyunsaturated fats, dairy products. Okay. Yeah, dietary approaches to control hypertension is DASH diet. Okay, we should quit the red meat. Yes. Increases the intake of vegetables high in nitrates known to reduce the blood pressure, such as leafy vegetables, beetroot, other beneficial foods, right? Including include the high in magnesium, calcium, potassium, such as avocado, nuts, seeds, legumes, tofu. We can use these things. These are coming under the DASH diet. Okay, DASH diet is nothing but what? Dietary approaches to control the hypertension. Okay, dietary approaches to control the hypertension. So it is very important to focus on the minerals, focus on the protein and low saturated fats. So we usually consider the polyunsaturated fats in the DASH diet. Okay, so that's how we go for the DASH diet, healthy diet. So first of all, we should look at the salt reduction, then healthy diet, then healthy drinks. Okay, healthy drinks are also important. So moderate consumption of coffee and green and black tea. Just reduce the coffee, green tea, or black tea, whatever you are taking. You can just reduce if you are taking in the high, if you are taking in the high dose, or uh, not the dose exactly, but if you are very high on tea or coffee, then reduce the dose of coffee and tea, because caffeine is always not good for the hypertensive patients. Okay, other beverages that can be beneficial include like hibiscus tea, pomegranate juice, beetroot juice, or cocoa. Okay, that can be included in your healthy diet, healthy drinks. Then moderation of alcohol consumption, definitely reduce your alcohol. If you are taking the two standard drinks or five standard drinks, reduce it to one standard drink. Or if you are taking five standard drinks, reduce it to two standard drinks per week. Okay, per week. So here you can see the recommended daily limit for the alcohol consumption is two standard drink for men and one standard drink for one and a half standard drink for women. Okay, that is per week, that is not every day. Okay, that's not every day, that's per week. Avoid the binge drinking. Okay, avoid the binge drinking along with binge watching. And then weight reduction, as we have seen, your 3.8 kg weight reduction in 1.5 year can reduce your blood pressure by 3 to 7 mmHg. Okay, then regular physical exercises, cardio, swimming, walking, jogging, cycling, yoga, these all helps in your lifestyle modification in the hypertensive patients. Then stress and mindfulness is very important, because stress is one of the major factor for hypertension, for cardiovascular problems, for diabetes, and for other multiple diseases. Okay, so if you are not reducing the stress, then you are definitely going to get the worst outcomes in hypertension and going to get the cardiovascular problems. It will increase the cardiovascular risk also, right? So always focus on reducing the stress, whether that is the workload, or that is the work related stress, or any kind of stress, just reduce it. Okay, so your age, at your age, it's very important to help you out and help others out also in reducing the stress, right? Then complementary or maybe alternative or traditional medicines. So large proportions of hypertensive patients are using complementary, alternative or traditional medicines, such as in Africa or China. So this is not supported, because usually the complementary or alternative medicines can affect on your kidney. Okay, these type of medicines can affect your kidney and can reduce the renal workload. Okay, and in that case you will go to the renal insufficiencies or acute kidney failure or chronic kidney failure. So in that cases you should avoid the alternative medicines when the patient is in the hypertension. Okay, then reduce the exposure to air pollen or the cold temperature. So cold temperature also can reduce your blood pressure. I mean, sorry, can increase your blood pressure. Why it can increase your blood pressure? Because it is leading, before you ask the question, it will lead to the vasoconstriction. Okay, cold temperature always lead to the vasoconstriction, and vasoconstriction lead to the peripheral resistance, and peripheral resistance lead to the high blood pressure. Okay, so cold temperature we should always avoid for the hypertensive patients. Okay, so these are the lifestyle modifications along with the treatment algorithm to the hypertensive patients. Now look at this. These are the all drugs what we can use in the hypertensive patients, and these are the all categories for hypertensive patients we use, right? So first of all, ACE inhibitors. Okay, first of all, ACE inhibitors. So as you can see, ACE inhibitors, all prils. Okay, all prils are the ACE inhibitors. Okay, ramipril, captopril, enalapril, lisinopril, perindopril. These all prils are ACE inhibitors, the first choice. Okay, this is the first choice of the drug. And then another first choice is, what is the first choice of drug? Another first choice of drug, guys. What is that? See, this is also the first choice of drug in all the guidelines. Okay, in all the guidelines, angiotensin antagonists are also the first choice of drugs, right? Losartan, candesartan, and olmesartan, telmisartan. So these are also the first choice of drugs, right? And then there is another category called calcium channel blockers. So calcium channel blockers, there are verapamil, diltiazem, nifedipine. So we consider all dipines to be in the all dipines to be in the calcium channel blockers, all sartans to be in the ARBs. Okay. When we are talking about sartans, we are talking about ARBs. When we are talking about prils, we are talking about ACE inhibitors. Okay. When we are talking about dipines, we are talking about CCBs. Okay. And then diuretics, there are multiple types of diuretics. First is thiazide diuretics. So one is hydrochlorothiazide, chlorothiazide, or indapamide. So these are the diuretics. Okay, and then there are high ceiling diuretics also, furosemide, and potassium spring also, like amloride or spironolactone. So can someone tell me what's the difference between high ceiling and potassium sparing? Yes, guys, can someone tell me what's the difference between high ceiling diuretics and potassium sparing diuretics? Yes, can someone tell me? Okay, by the time you write, and then there is another category called beta blockers. So all the O lol. Okay, if you can understand this LOL, laugh out of loud, it will go to all beta blockers. Okay, all beta blockers are lols. Okay, or all lols are your beta blockers. So beta blockers are two types again: beta adrenergic blockers and alpha beta adrenergic blockers, right? So why it is? See, some beta blockers are only inhibiting the beta adrenergic blockers, and some beta blockers are also inhibiting the alpha adrenergic blockers along with the beta adrenergic blockers. That's why we categorize into two different categories. One is the beta blockers which are blocking only beta adrenergic receptors. Okay, only beta adrenergic blockers. But some are there which are blocking alpha and beta, both adrenergic receptors. Okay, both adrenergic receptors. So these have the dual what we say, dual action on blood pressure. So these are more potent than the beta adrenergic blockers all alone, right? So we usually choose carvedilol over metoprolol or propranolol. But propranolol was the first drug, and propranolol has other properties. Propranolol can be given in the migraine also. Propranolol can be given in the pregnancy also, right? So this has multiple other this is the choice in multiple other complications and multiple other indications also, propranolol. But usually alpha and beta adrenergic receptors are blocked by these category. Okay, these both are beta blockers usually. So these alpha and beta adrenergic receptor blockers are having the advanced or extra activity. They can also block the alpha adrenergic receptors, right? So that's why but all LOL, wherever you see LOL, either that is atenolol, metoprolol, propranolol, carvedilol, or whatever, these all lols are beta blockers. Okay, and then there are only alpha adrenergic receptor blockers. This is alpha. Okay, so alpha adrenergic blockers like prazosin, these are progesin, terazosin, or phentolamine. these drugs are alpha adrenergic blockers only. Okay, and then there are some sympathetics also, so which controls the central sympathetic nervous system and control the hypertension, right? Like methyl dopa or clonidine. And there are some other vasodilators. So these vasodilators directly act upon your vessels, and these dilate your major vessels. Okay, dilate your major vessels and reduce the blood pressure by reducing the peripheral resistance. Okay, so in that hydrogen is there and minoxidil is there. Okay, what is the other use of minoxidil, guys? Other indication for minoxidil, anyone? Okay, high ceiling inhibitors for transport high ceiling act on ascending loop of Henle. Yes, yes. Hirsutism, yes, definitely. Baldness, yes. Hair growth, hirsutism, baldness, correct, absolutely. Okay, okay, okay. So before we go to the specific, slides, specific categories, can someone tell me? Let's go for the quick questions. Can someone tell me what is the maximum or initial dose of metoprolol? Metoprolol. What is the maximum dose or initial dose or highest dose of metoprolol? Tell me, guys. Metoprolol, 12.5 mg, 20 mg not there for metoprolol. Metoprolol is either, sorry, so sorry. Okay, metoprolol is either 12.5 mg, 25 mg, 50 mg. Okay, sorry, 50 mg. And highest dose is 100 mg for metoprolol per day. Okay, metoprolol is 12.5, 20, 25 or 50 mg. So that's the question here. What is the initial dose or highest dose for carvedilol? Tell me, guys. Why it is changing again and again? Yes, carvedilol dose. Carvedilol dose, guys. 1.25, 2.5 mg? Is it? No one knows. Okay. What's the tell me the simplest dose? Simplest dose. Tell me the dose of furosemide. Any dose of furosemide. Any dose. Any dose of furosemide. Yes, guys. Tell me any dose of furosemide. Furosemide. 40 mg, 20 mg, 40 mg, 10 mg, 40 mg. Okay, great. Perfect. 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 Tell me the dose of amlodipine. What is happening today? Tell me the dose of amlodipine, guys. Amlodipine dose. 5 mg, 2.5 mg, 5 mg, 10 mg. Yes, absolutely. Okay. Now, there is a very important question. There is very important question. Tell me the major side effect of amlodipine. Major side effect of amlodipine. Who knows? Major side effect of amlodipine. Dry cough. Pedal edema. Pedal edema is the, yes, pedal edema. Okay. Tell me the side effect of, the major side effect of ACE inhibitors. Major side effect of ACE inhibitors. AC. Major side effect of ACE inhibitors. Please tell me, guys. Major side effect of AC. Hyperkalemia, angioedema, or hyperkalemia. Yes. Okay. Great. That's really good. That's really good, guys. That's really good. That's really good. Can someone tell me the dose of spironolactone? Spironolactone. Spironolactone. 12.5 mg. 12.5 mg. Yes. Okay. So if I ask you one more question here, would you like to answer? Tell me, what do you understand by this? First dose effect. First dose effect. Tell me what is this first dose effect and in which drugs we usually should consider the first dose effect. Yes, guys, tell me. First dose effect. BP drops after taking the first dose. ACE inhibitors. Okay. Okay. ARBs. ACE inhibitors. ARBs. Yes. Okay. Yes. So first dose effect is usually when we give the drug, we should always start with the lowest dose. Okay. Always start with the lowest or mid lowest dose, whatever is the normal dose. We should always, whatever the blood pressure is, we should not start with the high dose. Otherwise, the patient can go to the hypotension. Okay. Patient can go to the hypotension. Patient can go to the hypotension. Okay, and if you want to avoid the patients to go to hypotension, always, start the dose with lower. Okay, dose with the lower dose or any drug. Okay, but usually it is considered in the case of ACE inhibitors and ARBs because these are known to rapid reducing the blood pressure. Rapidly they reduce the blood pressure. That's why we should always be careful when we are giving ACE inhibitors or ARBs. Okay, so RAS system, I told you that day, RAS system, let's revise it. So it all starts with where? It all starts with where, guys? It all starts with liver. From liver, the angiotensinogen, releases, and along with that, renin releases from the medullary apparatus or the, from your kidney, and uh, renin break down the angiotensinogen into angiotensin 1. Okay, angiotensin 1, and this process happens in liver. Okay, and then it goes to the lungs, and in lungs usually angiotensin is converted into angiotensin 2 by ACE, angiotensin converting enzyme, and then angiotensin converting enzyme will go to aldosterone system, and it will increase the aldosterone secretion or activate the aldosterone secretion. It will activate the sympathetic activity, and it will go to your pituitary gland also, and it will increase or activate the ATH secretion also, and it will go to your vessels, every vessel, every cell, and it will go and it will do the arterial vasoconstriction and increase the blood pressure. Okay, it increases the blood pressure, and in the kidney itself, your sodium and water retention happens, that will increase the fluid volume. Okay, that will increase the fluid volume, and fluid volume means the peripheral resistance will increase, and once the peripheral resistance increases means the blood pressure, or we can say hypertension. Okay, so that's how the hypertension happens, and let's not go to that. Let's come to the drugs. So the first drug category is our ACE inhibitors. Okay, our first category is ACE inhibitors. So usually, we use in primary and secondary both type of hypertension. Okay, ACE inhibitors can be used in both type of hypertension, either it is primary hypertension or secondary hypertension, doesn't matter. Okay, and benefit of using the ACE inhibitors, it does not interfere with your cardiovascular reflexes. Okay, it does not interfere with the patients who have asthma. Like beta blockers are restricted in the patients with asthma. Beta blockers can accelerate the symptoms of asthma. So as you know, ACE inhibitors are recommended in the patients with asthma and COPD and emphysema. Okay, we cannot give beta blockers. So these ACE inhibitors or ARB do not interfere with the patients who have asthma, right? And do not decrease the potassium levels also at to that extent. Like if you are giving the diuretics, so diuretics can suddenly decrease the potassium levels, but ACE inhibitors and ARBs are not known to that. They are known to hyperkalemia, hypokalemia, but not to that extent. If we are giving for the long term and the higher dose, then we can get the situation like hyperkalemia or hypokalemia. Okay, so do not cause the lethargy or weakness or sexual dysfunctions, right? And ACE inhibitors reduce the risk of cardiovascular mortality caused by the hypertension. So definitely, these are the recommended by the studies also. Okay, ACE inhibitors. So what is the exact exact mechanism of action? Simple, as we have understood by RAS system, RAS system. So simple, simple. From the kidney, from the kidney, renin, goes to the liver, okay, and it converts angiotensinogen, okay, into angiotensinogen 1, okay, angiotensin 1, sorry, tensin 1, and then it goes to the lungs, and in lungs, ACE ACE converts angiotensin 1 to angiotensin 2, okay, angiotensin 2. So ACE is angiotensin converting enzyme, okay, angiotensin converting enzyme. So what exactly angiotensin converting enzyme inhibitors, ACE inhibitors does is, ACE inhibitors will act on ACE, okay, ACE receptor, this is the receptor. So the drug molecules, the ACE molecules will come and will stick to the ACE inhibitor receptors, okay, I mean stick to the ACE receptors and occupy the entire surface of ACE receptors, so that ACE receptors cannot convert the angiotensin 1 to angiotensin 2. So angiotensin converting enzyme will take place in the lungs, okay, takes place, the entire mechanism takes place in the lungs, and angiotensin converting enzyme inhibitors, the ACE inhibitors, ramipril, enalapril, these will stop the conversion of angiotensin 1 to angiotensin 2. So there will be no angiotensin 2, and there will be no actions on sympathetic nervous system or adrenal gland or in the kidney, okay. So that's how we help out, that's how we help out, right guys? So that we can see here also, it stops the angiotensin converting enzyme here, stop the angiotensin converting enzyme, and stops this process here only in the lungs, okay, here only in the lungs. So it will not increase the BP ultimately, okay, it will not increase the BP ultimately. So I hope you understand, guys. Understand? Any question here or any query, anything you want to understand again? Yes, people, please tell me. This is the REST system only, RAS system. This is the entire RAS system. RAS system is included in the hypertension majorly, and that's how the ACE inhibitors or ARBs will work here. Okay. Yes, anyone? Any question here till this point of time? No? Then okay. So here there are some facts about ACE inhibitors. So ACE inhibitors work in the lungs to inhibit the angiotensin converting enzyme from angiotensin 1 to angiotensin 2. These medications cause an increase of bradykinin, which inhibits the kinase 2 also. And another name of kinase 2 is angiotensin converting enzyme. Okay. So that's how the blood pressure is increased. That's how the blood pressure is decreasing, right? So there are the drugs, all the prills, okay, all the prills are ACE inhibitors, okay guys, all the prills are ACE inhibitors. So ramipril, enalapril, lisinopril, captopril, benazepril, or fosinopril, moxapril, perindopril, quinapril, or trendolapril. So can someone tell me here, according to you, which one is the best drug in ACE inhibitors? Which one is the best drug in ACE inhibitors category? Can someone name me one, two, three, top three drugs in the ACE inhibitors? Tell me, guys. ACE inhibitors category. Can someone tell me? Ramipril, captopril. Sonika ma'am, what you want to repeat? What you want me to repeat? Please tell me. RAS system or what? Please tell me, ma'am. Okay, ramipril, RAS system. Definitely, I'll repeat it for you. Ramipril, captopril, perindopril. No, no, you guys are. See why I'm asking this question and what you have to consider. First of all, you have to keep in mind efficacy, side effect profile, affordability, okay, and evidences. Medical evidences, we call it evidence-based medicine. So evidences, these four, consider these four, and then tell me which one you consider as the first one. Okay, which one you consider the first one, like top three? Write me the top three ACE inhibitors. Okay, let's see. Let's see. Okay, let's see. Yes, see, look at this. Here you can understand all the things. Okay, so this is the drug name. Okay, benzoyl, captopril, enalapril, fosinopril, lisinopril, moxapril, perindopril, quinapril, ramipril, and tredolapil. Okay, tredolapil. And these are the considerations like people with the heart failure, reducing death. In the heart failures, reducing death, top is, we can say ramipril, tredolapil, enalapril, and captopril, okay, are known to reduce the mortality in heart failure. Okay, improving the quality of life, all these are improving the quality of life except beljapril. Okay, and then when it comes to heart attack people, when it comes to which is the major thing, cardiovascular risk, captopril, lisinopril, ramipril, and tredopryl are the top, which have the cardioprotective effect. Major cardioprotective effect seen in captopril and lisinopril and ramipril and tradopryl. Okay, enalapril does not have much cardioprotective effect. It is having, definitely it is having the positive point. It is having, the study says, the positive impact only. But if we look at the higher efficacy in heart attacks, definitely enalapril does not have that evidence. Okay, and the people who have diabetes and other heart risk factors, then we consider captopril, ramipril, and teradopril. Okay, perindopril has very good effect only in cardiovascular risk in diabetic patients. So the patients who are diabetic and hypertensive, we can consider perindopril in that. Okay, but again, in the top list, again, if you look at this, ramipril and teradopril and captopril are on the top. Okay, and then if you look at the reducing deaths in diabetes patients, reducing deaths in diabetes patients also with hypertension, then ramipril on the top. Okay, kidney patients, ramipril is the first choice, then second choice is enalapril. Okay, so look at this, first number, we always, the choice according to the evidences is ramipril, then it is enalapril. And if we have to think twice, if we have to think twice and we have to select one more, then we can go for captopril or tradopryl. Okay, go for tradopryl. They have, I mean, they all have the good qualities in different things, but if you look at, ramipril has the best effect everywhere. Ramipril has the best effects everywhere. So ramipril, then enalapril, then captopril, and then tradolapil. Okay, tradolapil can be given in the patients accordingly because they have the most impact, and these are the most efficacious drugs in different conditions. We don't just consider whichever is reducing the blood pressure significantly, but because the patients, or because everyone who is hypertensive are leading to some kind of cardiovascular events, or maybe some diabetic events, or they are leading to some kidney events, and they are having multiple comorbidities. So ramipril is the first choice in all type of comorbidities. Okay, then enalapril is the choice of drug in all type of mortalities or all type of comorbidities, right? So understand guys, ramipril is the first choice always, and then enalapril, and then captopril we can go for, and then tradopryl, right? Understand? Anything else here? Okay, now let's see first dose effect. So usually occur with the initial dose, worse in the patients with severe hypertension like chronic hypertension, or who are on diuretics. Okay, or who are having the volume depleted, like the patients who have vomited recently, or the patients who had diarrhea recently, or the patients who is not having very high volume of the fluid in the body. So in such patients we should always avoid the high dose of uh, antihypertensives. Okay, we should start with low dose, because these kind of patients can face the first dose hypotension. These kind of patients can face the first dose hypotension and can lead to even the coma. Okay, so in such patients we should not give, or we should not start with high dose. Okay, and the major side effect is cough. Okay, major side effect is cough because of because of raised levels of bradykinin. Okay, raised levels of, high levels of bradykinin. Why high levels of bradykinin? Because angiotensin 1, understand guys, understand, very important. Okay, you guys have to understand, because ACE inhibitors converts angiotensin 1 into angiotensin 2, right? Angiotensin 2, okay? And bradykinin is angiotensin 1. So when angiotensin 1 is not converted into angiotensin 2 because of the ACE inhibitors, so there will be sudden raise in angiotensin 1 levels in the lungs, and that can cause the allergic reactions, that can cause, the cough, that can cause the cough or angioedema as well. Understand? This is simple. This is simple because see, ACE inhibitors convert what? I mean, sorry, ACE converts what? ACE converts angiotensin 1 into angiotensin 2, right? So when ACE inhibitors goes in the body, in the lungs, those will inhibit the ACE. ACE inhibitors will inhibit the ACE. So what happens is angiotensin 1 will not be converted into angiotensin 2, and angiotensin 1 is also called as kinase 2 or bradykinin, right? So that bradykinin will not be converted into angiotensin 2, sorry, angiotensin 2, and that's how there will be the raised levels of bradykinin that can, I mean, bradykinins are known for allergies or cough or angioedemas. Understand? So cough occurs in 10 to 15% of the patients, and it is more common in women and elderly patients. Okay. Then hyperkalemia. Okay, potassium levels rise due to inhibition of aldosterone, definitely, and it can increase the potassium levels. Then renal failure, very minor renal failure. Nowadays, we can avoid in the new modifications in the drugs. We can avoid the renal failure by say ACE inhibitors, and even the ACE inhibitors are, low dose ACE inhibitors are recommended in even the renal failure hypertensive patients or renal failure cardiac patients. Okay, low dose ACE inhibitors can be given in such patients, right? And then fatal injury, in the second and third trimesters, a fetus can experience hypotension, hyperkalemia, skull hypoplasia, renal failure, or death. So ACE inhibitors are banned in what? Banned in pregnancy. We should not give the ACE inhibitors in pregnancy X category drugs. These are X category drugs. We should not be given in case of pregnant women. Okay, guys. Then there are drug interactions like with the lithium and allopurinol and NSAIDs and potassium, increasing medications like it can increase the potassium more with few, some more diuretics we should not give, and we should not give ACE inhibitors with ARBs and such other antihypertensive drugs also when it is not recommended. Okay, we should not initially start with dual therapy or triple therapy. We should wait for some time and then we should go for it. Okay, what is the monitoring needed when we are giving ACE inhibitors to the to the patients? First of all, weight loss, and we should encourage the patients to quit smoking and decrease the alcohol intake, and we should tell them to go for exercises, right? What are the major monitorings? Potassium levels, because it should not raise in the potassium levels. Then it should not lead to the kidney failure, so BUN and creatinine must be checked. So what is BUN, guys? Can someone tell me what is BUN? Blood, what is BUN? Anyone?
Blood urea nitrogen.
Yes, blood urea nitrogen should be checked. Okay, and then monitor for the hypotension. Monitor for the hypotension or fluid volume if the patient is having excessive sweating, diarrhea, vomiting, or dehydration. Okay, dehydration. So monitor the first dose hypotension. Definitely, we should monitor the first dose hypotension for 2 to 3 days, and we should educate the patients about the signs of hypotension. If somebody is having the signs of hypotension, like okay, so tell me, what are the signs of hypotension, guys? What are the signs of hypotension? Tell me. What are the signs of hypotension? We have to educate the patients when we are giving ACE inhibitors or ARBs or any antihypertensive drugs. We should educate the patients for these things. Okay, giddiness, weakness, dizziness, sweating, yes, nausea, confusion, yes, absolutely. So these are the signs of ACE inhibitors. Okay, so this is monitoring, and this is the summary of your ACE inhibitors. Okay, so all the ACE inhibitors can be known by PRIL. Okay, April. April. Okay, so captopril, ramipril, this is the normal suffix pril, so you can understand by April. Okay, so fosinopril, lisinopril, benzoyl quinapril, whatever is there, pril means your ACE inhibitors. Okay, and then what else? Medical use of ACE inhibitors indications can be remembered by this, like hypertension, congestive heart failure. First drug, first choice of drug in heart failure also. ACE inhibitors are the first choice of drug in heart failure. Okay, then myocardial infarction, prophylaxis of cardiovascular risk subject, diabetic nephropathy, or scleroderma crisis, we can give those things. Okay, so what exactly we should remember? Home care makes patient definitely strong. If you remember this, then take all the initiatives. H for hypertension, C for congestive heart failure, M for myocardial infarction, P for your prophylaxis for cardiovascular risk subject, and D for diabetic nephropathy, S for scleroderma. Okay, so this is to remember the indications of ACE inhibitors. Home care makes the patient definitely strong. And if you remember captopril, captopril is one of the drug. All the side effects can be understand easily. Just remember, what are the side effects of ACE inhibitors? Captopril. What are the side effects of ACE inhibitors? Captopril. C for cough, A for allergic reactions because of bradykinin, and P for potassium elevation means your hyperkalemia, T for taste change, O for edema, angioedema, and photosensitivity, and R for renal failure, I for indigestion, L for hypotension, low blood pressure. So these are all the significant or standard side effect of ACE inhibitors. Understand? So captopril is the what we say abbreviation to remember the side effects of ACE inhibitors. Okay, guys. So that's all for today's class. I'll take slowly. I'll scale up my stamina to take the classes slowly. So that's all for today's class. We'll take the class another class tomorrow. Okay, guys. Okay. So any questions till now? Any questions till now, guys? We have completed the ACE inhibitors. Thank you. Ma'am, so I'll describe the RAS system once more. Okay, I'll describe the RAS system once more. So here is the RAS system. So what happens is, liver and kidney both works together when, it all starts. How exactly it start is when our body, our body is, it goes to the hypotension. Usually our body face the low blood pressure, low peripheral resistance. Actually, if we say in the simple words, our body face or body feels the low peripheral resistance. Okay, when our body feels there is low peripheral resistance, suddenly what happens is liver starts producing or secreting the angiotensin, and kidney starts producing renin. Okay, kidney starts producing renin in case of hypotension, low blood pressure, and low peripheral resistance. The main cause is low peripheral resistance. Okay, or low volume. So whenever is the low fluid volume in the body, it happens renin and liver, renin and angiotensin comes together. That happens, all happens in the kidney and liver. So here what happens is the renin goes to the angiotensinogen and converts it into the angiotensin 1. Now angiotensin goes to the lungs. Okay, in the lungs what happens is, in the lungs, when there is the raised volume or there is a raised level of angiotensin 1 or bradykinin. Okay, so what happens is lungs start secreting ACE is angiotensin converting enzyme, and angiotensin converting enzyme converts angiotensinogen 1 into angiotensinogen 2. Okay, and angiotensinogen goes to different parts of different systems of the body, like symptomatic activity, it's symptomatic nervous system, and it increases the symptomatic activities. It goes to the aldosterone. Okay, and it increases the aldosterone secretion. Okay, and aldosterone secretion again imbalance the sodium water retention. Okay, and it goes to every vessel, angiotensinogen 2, and it causes the vasoconstriction or it raises the peripheral resistance. It goes to the pituitary gland also, and activate the pituitary gland to secrete more ADH. Okay, more ADH that will again go and cause the sodium water retention in the kidney. So wherever there is these all activities leads to the sodium water retention in the kidney, and it will increase the fluid overload in your body. Wherever there is a fluid overload, it will include, it will increase the peripheral resistance drastically. And whenever the peripheral resistance increases, that means your blood pressure is increases. That's how the RAS system lead to the blood pressure. Okay, so that's very simple to understand. Okay, thank you everyone, thank you. Thank you. Take care, guys. We'll see you tomorrow. Okay. We'll see you in the tomorrow's class. Bye bye. Take care, guys. Good night. Good night.